Live now. You can go ahead.
Good afternoon, everyone. Welcome to YOSI iROCK Prelims Session 2. Today on 9th February from 2 to 4. Our subspecialty today is glaucoma. We are very honored to have with us today our judges, Dr. Satyan, Dr. Avi Kumar Roy, Dr. Sunita Dubey, and Dr. Vanita Patakre. We are very happy to know that everyone else has shown a very good response to this contest. This is for postgraduate ophthalmic residents. Today we have 4 teams participating with us. The first is Team Vitreous Vanguards. The second is Team Vision Virtuosus. And then we have Team Illuminati and Team Synergist Squad. We welcome you all. Our moderators for today will be me, Dr. Arshi Singh, Dr. Maushami Banerjee, and Dr. Neemal Khatwani. So without further ado, let me move ahead with the introduction to iROCK.
Archie, is there any voice?
Yes, there is. Can you not hear, sir? Can the voice not be heard?
You
Yes,
have
Dr.
enabled
Arshi,
voice.
voice is...
We can hear you,
Yes.
Archie. We can hear you well. Yeah.
Yeah, you can hear you, but the video has no
The
sound.
audio with the video clip is not being heard.
Yeah. Okay, I'll talk about this. Also, the presentation is it is still, but presentation is still.
Arshi, you can stop sharing and share again. While sharing, you just enable share sound. No, you can stop sharing on Zoom, and while sharing again, there is an option to share sound. Just enable that and share.
Now we can hear you. Yeah.
Perfect. All right. So just to summarize again, this is our team of the Young Ophthalmologist Society of India. This is our governing council led by President Devakant Mishra, sir. This is our team of executive members who are very dynamic. A lot of them are involved in this contest. YOSI has multiple activities that a lot of residents can be part of. This is the team for the Residents of Ophthalmic Contest headed by Dr. Nupur Goyal. And this is the logo that was creatively designed by Dr. Samir, who is one of our executive members. So we invite all our residents to please participate. The registration will again be open. This is only for junior residents, and SRs can participate separately in the Fellows Face-Off contest. The top teams, 2 teams from the preliminary contest will go for the further rounds, and the 7 finalist team will make it to YOSICon with awarding of the travel grants as well. And all these certificates will be given on the e-platform. We hope you all enjoy the event today. As I said, we'll be reopening registrations for the next round from 15th February onwards. We have 4 rounds today. The first is the iLeague, which is a seminar presentation. The second is a creative round, which is called Pupils Got Talent. The second is a quiz, the Knowledge Nexus. And then you have an unscrambled contest known as the Wordsmith round. Also, we encourage the audience to participate or to include the postgraduates, and you will all get awards as well. There'll be 3 audience questions. To introduce our esteemed judges for today, we have Dr. Satyan, who is the director of Satyan Eye Care Hospital and Coimbatore Glaucoma Foundation. He's also the president of the Glaucoma Society of India. Sir has more than 30 years of experience in ophthalmology and has also been the chief at Arvind Eye Hospital for 20 years. He's the ex-member of the AIOS Managing Committee representing TNOA and is also held the past president state for the Coimbatore Society of Ophthalmic Surgeons. He's won multiple awards, including the Most Promising Research Presentation Award by the GSI and Excellence in Patient Experience by the Federation of International Indian Chambers of Commerce and Industry. So welcome you here and thank you so much for sparing time. The next we have is our illustrious ma'am, Dr. Sunita Jube. She is the medical director and the director of glaucoma services at Dr. Shroff's Charity Eye Hospital. She did her fellowship in glaucoma at Wills Eye Foundation, as has extensive experience in the management of glaucoma, pediatric, refractory, and with the special interest in GDDs and MIGS. She has more than 150 publications to her name, has also been the treasurer of the GSI from 2012 to 2014. Again, ma'am has won multiple awards from AIOS, ICGS, DOS, and Vision 2020, and is also part of Orbis International. Thank you so much, ma'am, for sparing time today and for leading the residents today. Our next speaker, our next judge is one of my favorite teachers to hear from, Dr. Vanita Pathakre. Ma'am is the Director of Glaucoma and Senior Glaucoma Cataract Specialist at Center for Sight, Hyderabad. She is one of the pioneer surgeons for MIGS, was the first Indian to do a MIGS eye stent, and also has multiple publications in ECP. She has multiple awards to her name, as you can see over here. And the most special ones being, she's been the international hero 3 times in a row by AIOS, and also is a fellow in glaucoma surgeries by the International Society of Glaucoma Surgeries. Thank you, ma'am, again for being here.
Thanks, Arshi.
Is my teacher, someone who's taught me during my DNB residency. Sir is Dr. Avik Kumar Roy. He is the head of glaucoma services at MTC campus LV Prasad Eye Institute, Bhubaneswar. His interest is primarily for complex glaucoma and MIGS surgeries. Sir did his fellowship at LV Prasad Eye Institute and thereafter has been a consultant at LV Prasad Eye Institute, Hyderabad, and thereafter at Bhubaneswar. Thank you, sir, for being here. Now I would like to introduce our moderators for today. This is me. I am Dr. Arshi Singh. I'm an associate professor in glaucoma services at Guru Nanak Eye Center, and I'm very thankful to be here. I'm also an executive member of the YOSI. Then we have Dr. Maushmi Banerjee. Ma'am did her MD from API Center AIMS and also her SR-ship there in the Retina, Uvea, Phaco-Refractive and ROP Services Unit. She's an assistant professor at Maharaja Agrasen Medical College with more than 60 publications to her name and multiple awards to her name as well. Then we have Dr. Neelam Khatwani. She's working as a VR surgeon and ROP specialist in Gurgaon and did her fellowship from HV Desai Eye Hospital in Pune and also from Shroff Eye Center in Delhi. She's an active member of the YOSI and also enjoys traveling and cooking. Thank you for being here. Now to move on to our participants. The first team today is the Vitreous Vanguards from the MGM Medical College, Indore, Madhya Pradesh. We have the captain, Dr. Rishabh Khare, who's a PG second year. We have Dr. Shrishti Upadhyay and Dr. Arpita Shringi. They are both second year residents. Welcome, Vitreous Vanguards. The second team is the Vision Virtuosos. They are from Arvind Eye Hospital, Madurai. The team captain is K. Ashwarya and her 2 team members are Dr. Meghna Grandhi and Dr. Sabrinath Arunagiri. They're all third year residents. The third team is Synergist Squad, again from Arvind Eye Hospital, Madurai. The team captain is Dr. Shobhana and the other 2 team members are Dr. Vinita and Dr. Neha Rashid. They are second and first year residents respectively. Welcome, Synergists. The last team for today is the Illuminati. They are from AFMC Mumbai. They are led by team captain Dr. Varsha Chauhan, and the team members are Dr. Sharan and Dr. Mehek. They are all three of them second-year residents. I welcome all of you to this iROCK session 2 for today. So the outline for today, as discussed, will be the first 4 rounds are the seminar, the creative round, the knowledge nexus, and the Wordsmith war. So the first 2 rounds judges will be the ones that will be marked first, and then we'll proceed to the quiz and the unscramble round. So again, let us start with the seminar presentation and the I-League. Our first team to present today, please start sharing your screen. The rounds for today, the rules are going to be judges to note that the time limit given to the team is 5 minutes. If they exceed the time, there will be negative marks, and there'll be a question and answer session for the next 2 minutes after the presentation, and they will be marked according to the answers that they give. The total marks are for 20, and the session for today, all the topics are related to glaucoma. The teams also have their mentors present with them, and we welcome them all. Thank you, ma'ams and sirs, for joining us today and for showing support to your team and your students for being here. I'm going to stop my stream sharing. Team 1, please start sharing your screen.
Yes, ma'am. Before starting the presentation, our consultant, Dr. Manushree Gautam ma'am, has joined the webinar. Hello.
Yes, Rishabh, you can start your time.
Okay. Yes, ma'am. So I'll start my presentation. The topic is primary open-angle glaucoma. Very good afternoon to all the panelists and fellow residents. So primary open-angle glaucoma is a glaucomatous chronic optic neuropathy, which is characterized by IOP more than 21 mm Hg at some stages, characteristic visual field losses, and absence of secondary cause of glaucoma. It can be classified into primary and secondary. The primary are juvenile glaucoma, normal tension glaucoma, and ocular hypertension, while secondary are steroid-induced pseudoexfoliation syndrome, pigment dispersion syndrome, traumatic, and pseudophakic. When we look at the variants of POAG, we have open-angle glaucoma, normal tension glaucoma, juvenile open-angle glaucoma, ocular hypertension, and a glaucoma suspect patient. If we look at the demographic risk factors for glaucoma, we have demographic factors, ocular factors, and systemic factors. The demographic and systemic risk factors for POAG are race, age, family history, and socioeconomic risk factors. While we try to understand the factors influencing IOP, we have central corneal thickness, translaminar pressure gradient, peripapillary atrophy, myopia, and nerve fiber layer thickness. The impact of systemic and lifestyle factors on POAG, we have got diabetes, hypertension, systolic perfusion pressure, migraine, and lifestyle factors. When we look at the genes involved in POAG, we have myosilin, optinurin, and WDR36. If we look at the way which how the IOP pressure happens, there's increased aqueous humor production, trabecular meshwork thickening, there's a deposition of amorphous material in the spaces, Schlem's canal collapse, and increased intraocular pressure. When we look at the pathogenesis, we have got 2 theories. It's mechanical theory and the ischemic theory. The diagram is taken from the Yarn of Tradition diagram, which is taken from International Ophthalmology Journal. When you look at the clinical features of POAG, we have got asymptomatic disease, which until significant vision, mild eye ache, visual field defect or scotoma, frequent changes of presbyopic glasses, delayed adaptation, significant loss of vision and blindness. When we evaluate the patient, we look for refractive status. We try to rule out the secondary causes of glaucoma, family history, past medical history, drug history, and history of smoking or alcohol. When we evaluate the patient, the anterior segment, we look out for corneal haze. We measure the AC by von Herrick's method. We do gonioscopy for AC angle, pupil reaction, evidence of secondary causes, and IOP. For gonioscopy classification, we have got 4 classification. We have Schaeffer's, Shee's, Spades, and RP center classification. These are the gonioscopy images taken from the internet. When we do a fundus examination, we have got mechanical and vascular signs. The mechanical signs are large optic cup, asymmetric cup, progressive enlargement of cup, narrowing notching of cup, vertical elongation of cup, RNFL loss, and laminar dot sign. While the vascular signs are disc hemorrhage, nasal displacement of vessel, bearing of circumlinear vessel, tortuosity, bayoneting, arterial narrowing, and collateral zone disc. While recording and documentation of disc is very important. The progression of field defects can be classified into following types, and the diagram for the same is given here. The Anderson's criteria for glaucomatous field defect is very important. On an abnormal glaucoma hemifield test, we have got outside normal limits on at least 2 consecutive occasions, a cluster of 3 or more non-edge points in a location typical for glaucoma, all of which are depressed on PSD that occurs in less than 5% of normal individual on 2 consecutive fields. Now, the aim of the management is to prevent nerve fiber loss, to prevent any further visual field deterioration, to retain the quality of life of the patient, to monitor and avoid any drug reaction of anti-glaucoma medication. We have got an armamentarium of drugs for pharmacological management of glaucoma. The drug action is given in this diagram taken from internet. So when we look for the glaucoma treatment protocol, the first line in drug are prostaglandin analogs or beta blocker. If there's ineffective response, we can change to a different monotherapy. A second drug is added if there's ineffective response, and a third drug can be also added if there is insufficient pressure reduction. But even despite after maximal medical therapy, there's no response, we can go for surgical alternative, and laser trabeculoplasty can be done at any stage of the procedure. For laser therapy, we have got SLT and ALT. For indication of maximum medical therapy and supplement, for the moderate glaucoma, ALT is more destructive, focused on the junction of anterior pigmented, non-pigmented edge of trabecular meshwork. But SLT is less destructive and selectively target pigmented cell. Surgical management, we have got MIGS, trabeculectomy, and glaucoma drainage devices. MIGS causes minimal disruption of normal anatomy. It has an IOP lowering efficacy that justifies the approach and high safety profile. Trabeculectomy is a gold standard, and the long-term pressure lowering effect is good. And glaucoma drainage devices are reserved for patients whom the surgical and medical therapies have very low chance of success, and there's still reasonable potential for vision. So finally, I would like to end with this statement that POHE requires awareness, vigilance, and lifelong care. Thank you.
Very well presented, team 1, and well on time. Good use of graphics. We'll move ahead to the judges' question and answers and the comments, please. Ma'am, sirs.
Can I ask a question, please?
Yes, ma'am.
Yeah. First and foremost, how do you exclude secondary causes? And second, is ocular hypertension a glaucoma? In other words, when is it called a glaucoma?
Ma'am, if first of all, we'll try to have a detailed examination of the patient as well as history taking to ruling off for the secondary causes.
Detailed, what detailed examination?
Detailed optic disc examination, anterior chamber examination, ma'am, as well as visual field defects also. We'll do a perimetry, ma'am, for visual field defects also.
No, but the visual fields don't give you secondary, cause, you don't find out secondary causes. So the word I'm looking for is a detailed slit lamp examination. Okay, that will give you most
chamber examination.
A history and a detailed slit lamp examination. My second question was, when do you call it glaucoma?
Ma'am, a patient should have, for glaucoma, first of all, the word is chronic progressive optic neuropathy. So patient should have optic disc changes, and the perimetry changes, that the visual field loss should correspond to the RNFL loss in the patient's eye. And ma'am, with sometimes the pressure can be pressure can rise, and criteria is important, ma'am.
Correct. So then
perimetry, ma'am.
The point you had that the pressure should be greater than 21, and you're including NTG in that spectrum, is incorrect.
Ma'am,
actually, pressure has gone out of the definition of glaucoma a long time ago. Okay.
Yes, ma'am.
IOP is just a risk factor.
Yes, ma'am.
Right? So that is something you guys need to understand very early on in your career. That it is the disc that you need to examine.
Yes, ma'am.
And the disc is what will give you the idea whether glaucoma is present or not. Okay, thanks.
So how many, still there's some time remaining. So it's a very nice presentation. You have covered all the basics. So I would just like to now know about, since your exam going, about the future directions in, POAG treatment.
Yes, ma'am.
So what are the emerging therapies and drug delivery systems? Do you know about them?
Ma'am, pharmacological management, we have got ROK kinase inhibitors, ma'am, the newest ones available, ma'am, ripasutil, netasutil, ma'am. They are based on the ROK kinase
They are in the
mechanism.
market already. So is there
Yes,
any
ma'am.
new emerging therapies like which are still in the investigation time? Because I think in PGs you will be asked questions about the future treatment also, or any new drug delivery systems you know about? Some new drug delivery systems?
Ma'am, we have got, ma'am, drugs like latanoprost, Bunod, ma'am, which is latanoprost plus Bunod, ma'am, which is a nitric oxide delivery system, ma'am.
Okay, so
And
this
we
is
have
this
also,
new combination which is yet
yes,
to
ma'am.
come. And
And
any
ma'am,
drug delivery like extended drug delivery system?
sustained release implants we have, ma'am.
Okay.
In the forms of pellet, ma'am, bimatoprost implants are there, ma'am.
Okay. So now there's a lot of talk about the artificial intelligence, and so can you, use this technology for the early diagnosis, which is very important for the glaucoma? Early
Ma'am,
diagnosis?
Ma'am,
Yes.
I think we can, the AI can provide a detailed explanation for perimetric changes in a patient's eye, ma'am. We can even easily identify normal, which we think is a normal, what we think is a normal perimetry, but based on the indices and different things, ma'am, we can stratify whether the patient is,
So AI for
is
the
going
optic
into
nerve head and
glaucoma.
so it is not for the visual right now, visual fields, but the optic nerve head and imaging. So
Yes,
you
ma'am.
can
Yes, ma'am.
identify the early changes even if, some specialist is not examining the patient, even at the in the community setting with the help of
Yes, ma'am.
artificial intelligence, you can, make a difference and diagnose the glaucoma early.
Yes, ma'am.
Okay.
Yes, ma'am. Yes, ma'am.
Yeah, I have one comment only. A very basic question. So, do you know about the role of CCT in the open angle glaucoma?
Yes, ma'am. Yes, sorry, sir. Yes, sir. Central corneal thickness, sir. Because of central corneal thickness, if there's decreased central corneal thickness is less, sir, it will provide an overestimation of the pressure, sir. So, sorry, so underestimation of the pressure. So because the cornea is thin, while the thickness is more than 450 or 445 micrometers, it will provide an overestimation of the pressure, sir. So it can give either a negative reading or
So, what
negative.
will be the like the cutoff limit, like the average CCT?
So we take it to be 445 microns, so 420 to 450, sir.
It is not 420, it is like 520, 530.
525. Yes, sir.
Yeah.
Yes. Yes.
So, and what equation do you follow, like you textbooks?
So we take
There are
the
several normograms available, but if you are asked in the exam, so what will be your answer from that?
so with every 10 micron, so what a formula is that we take the IOP, which is measured. We have measured the IOP, and we take the thickness of the patient's cornea, and for every 10 micron change in the thickness, 1 mm rise or a decrease of the pressure can happen, sir.
Avik, I do not think we should be confusing them with this at
Yeah.
all. There is no internationally accepted nomogram that actually agrees on the conversion. There was a very early study done, quite a few years ago, 1975, by Ehlers, who compared manometry and Goldman tonometry, and found that for every 50 microns of thinning or thickening, there's a 2.5 millimeter mercury change. So what we see is thin cornea, okay, greater risk, thick cornea, lesser risk. You don't actually make a correction. This is also something I feel you guys need to know early on, because there is a lot of, I feel, misguidance on this.
Yes, ma'am.
Will you agree, Avik?
Yeah, yes. From the PG's perspective, I guess. So during the exam, they might be asked this question. That's why I'll ask.
So I think any member of the team can answer, not necessarily the presenter,
Yeah.
because there's a team. So anyone can answer.
Yes, ma'am.
It's an educational process. So, you don't have to think of it as only as a competition. Yeah.
Satyan sir, questions, please.
There is no questions. All questions have been asked. They did a good presentation.
Thank you,
We'll
sir.
just go ahead. Yeah.
Great job, team
I'll
one.
just listen to this first and then let me come back.
Okay, can we have team two? Can you start sharing, please? The vision virtuosos.
Ma'am, are the slides visible?
Yes, they
Hello?
are visible. Just make them into the full screen mode.
Ma'am, is it share?
Drag the zoom bar above and then click on the slide share on this full screen option, on the slideshow option.
Ma'am, is it visible now? Hello?
Yes.
Hello? Can you hear
Yes,
me,
it's
ma'am?
visible.
Can I start?
Yes, please.
So I think all of you must have guessed the topic by now. Yes, it is pseudoexfoliation. Pseudoexfoliation is an age-related disorder with elastic microfibrillopathy characterized by progressive production and deposition of abnormal fibrillary material in both ocular as well as extraocular tissues. It is seen in the pupillary border, lens, other sites like conjunctiva as well as orbital tissues. Systemic sites include skin, heart, lung, kidney, as well as visible organs. This is true exfoliation, which is seen in glass blowers, where there is delamination of the superficial layers of the lens capsule, mainly because of infrared radiation as well as exposure to extremely high temperature. Coming to the epidemiology, it is seen in 60 to 70 years females, most common in Scandinavian countries as well as parts of Africa. Pseudoexfoliation syndrome is common in females, whereas pseudoexfoliation glaucoma is common in both and accounts for 30% of open-angle glaucoma. Coming to the etiology, genetic factors including mutations in LOXL1 gene and non-genetic factors like UVA radiation, dietary factors, as well as autoimmune factors are responsible for pseudoexfoliation. Pathogenesis-wise, it causes acute open-angle glaucoma by pigment dispersion and transient IOP rise after pupillary dilatation. It causes secondary open-angle glaucoma by exfoliative material which gets deposited at juxtacanalicular meshwork, leading to its disorganization and clogs its trabecular meshwork. Secondary angle closure glaucoma, which is mainly caused because of zonular weakness as well as forward movement of the lens, causing pupillary blur. Normal tension glaucoma, mainly because of degeneration of the vascular endothelial cells as well as pericyte. And neovascular glaucoma, caused mainly because of secondary to CRB. Now coming to the clinical features. Cornea, we can see Krukenberg spindles, scattered flakes as well as pigments on the endothelial surface. Iris, there is deposition of exfoliative material on the pupillary margin as well as iris sphincter. It's also called as a starry sky appearance as well as moth-eaten appearance. Coming to the pupil, there is increased iris rigidity as well as poor mydriasis. In the lens, exfoliative material is seen on the anterior lens surface. There are three zones: the central disc, which is homogeneous mantled fibrillar layer with rolled up edges, an intermediate zone 1 to 2 millimeter wide, devoid of any pseudoexfoliative material, consisting of the normal lens capsule, and a peripheral granular zone that is nodular aggregation.
Doctor, can I just interrupt for a moment? Can you come a little closer to the mic, or because I'm maybe I'm a little not able to hear you well.
So now can you hear me, sir?
Yeah, now it is much better.
Yeah, the central, there are three zones. Then you have the pre-equatorial zone, hidden by the iris and nodular excrescences, as well as there are pathological alterations of the lens zonules as well as the capsule. In the angle of the anterior chamber, there is pseudoexfoliative material, which is most commonly seen, patchy trabecular meshwork presentation, and sampolicity lines. In the zonules, there are basically broken and flayed with tendency for subluxation of lens. Optic nerve head is associated with disc stopping as well as large area of pallor. In the retina, there is central retinal vein occlusion. Mechanisms by which pseudoexfoliation causes glaucoma: mechanical, because of the pseudoexfoliation material deposits in the trabecular meshwork, degenerate long-term changes, and increased pigment dispersion, and increased resistance increased outflow as well as increased IOP and breakdown of the blood-aqueous barrier, resulting in increased protein in the aqueous. The various complications which the patient can undergo during a cataract surgery are myotic pupil, corneal endothelial compromise, phacodonosis, postoperative inflammation, zonular dialysis, as well as lens subluxation. Coming to the medical management, there is poor response to treatment, multiple drugs are required, pilocarpine and prostaglandin analogs can be used, carbonic anhydrase inhibitors are avoided because of endothelial compromise. But coming to the laser, the response is basically good, but the effect is short-lived. Post-laser IOP spike is common. Gap PA can be done in case of angle closure glaucoma. And coming to trabeculoplasty, you have ALT as well as SLT. So surgeries available are our trabeculectomy, the glaucoma drainage devices, non-penetrating glaucoma surgeries, and trabecular aspiration. Thank you. Now I invite my moderator, Dr. Sharmila ma'am, to speak a few words on our topic pseudoexfoliation.
Good afternoon, judges. Good afternoon, YOSI and the moderators, and a very good initiative taken by the YOSI to involve postgraduates in such a program. At the outset, the pseudoexfoliation, we all know that it's a very, very important topic, and we all face day in and day out a lot of problems during cataract surgery because of pseudoexfoliation. Even though it is not always going to be glaucoma, even the mere presence of pseudoexfoliation itself is prone for potential complications. So our team headed by Aishwarya, Meghna, and Sabrinath have taken a great initiative to prepare this. So I hope they will be able to answer the questions that is thrown out on them. And as Vanita rightly mentioned, it is a learning process. And I'm sure even if winning or losing, this is going to be a learning process for all postgraduates. I wish all the team members very best of luck for this. Thank you.
Thank you, Sharmila ma'am, for your feedback. It is so wonderful that the mentors were able to join to support all the team members. I think kudos to the participants as well as the teachers. I hope this trend continues. Thank you. Now, moving ahead to the judges' questions. Please, ma'am, sirs, could you start asking the questions?
Yeah. So, good presentation, doctor. Only thing is the mic wasn't too close, so half of it I couldn't hear you well. Anyway, so just few comments on your slides. Just to improve, just try to avoid all these animations, unnecessary photographs, all this. So just concentrate on the clinical thing so that people's attention will be on more of the subject rather than on your animations. So that was taught to me, I'm talking about 25 years ago. RDS used to say that don't put too many animations. Concentration will just go off. So just a tip for your presentation. The second thing is, can you just answer, is it pseudoexfoliation a primary glaucoma or is it a secondary glaucoma, or which category it comes under?
We can't hear you.
Secondary.
Okay.
Yes.
Team 2, please come close to your mics.
And is that anything you can talk about the IOP in pseudoexfoliation glaucoma versus the other primary glaucomas? Is there something very peculiar about the intraocular pressures in PXF?
Dilatation, IOP spikes.
We are not able to hear. Just take one of you take the question. And one of you can answer. Don't put everybody into that.
Sir, there is increased risk of post-dilatation IOP risk and increased risk of diurnal variation in the IOP, sir. More risk of diurnal variations will be present, sir.
Usually in pseudoexfoliation, the IOPs are always much higher than the normal type of primary POA, primary open angle glaucomas. That is one of the main things. So that is why these patients progress much faster. The fluctuations are also higher, and also the IOPs are also on the higher side.
Okay, sir.
One thing I noticed in this clinical presentation, you said NTG. I doubt pseudoexfoliation glaucoma presents with normal pressure. If it is, you are seeing a glaucomatous disc damage, probably it is an NTG rather than a pseudoexfoliative glaucoma. It is just coincidental that pseudoexfoliation is present in that eye. All pseudoexfoliations do not give glaucoma. You have to know that also.
Okay, ma'am. Yes, ma'am.
The second thing is, I saw that you, in the clinical presentation, you said you showed a picture of corneal verticillata. Like Satyan, I couldn't hear very well, but the visuals were more for pigment dispersion rather than pseudoexfoliation glaucoma. So you got to be very careful.
They talked about Fukenberg spindle. I wanted to
Yes.
say it is not
Yes.
common. It is
No,
common
you
in
do
pigment
have pigment,
Yeah.
correct, but you don't have it in the form of a vertical
Yeah,
spindle, and you certainly don't see a mid-peripheral iris transillumination defect. That is very typical of PDS. And unfortunately, in our kind of dark eyes, we don't even see that. How we diagnose PDS and pseudoexfoliation, gonioscopy is very useful because in pigment dispersion, you have a concave configuration of the iris. The iris in the periphery dips towards the zonules. That is where it rubs, and that is where the pigment comes from.
So although they come in DD, pigment dispersion and pseudoexfoliation, but
it's
the
not.
clinical picture is quite different. In pseudoexfoliation, as Dr. Vanita rightly said, the iris configuration is not concave. It is, in fact, the AC becomes shallow because of the zonular laxity in pseudoexfoliation. So sometimes you need to do PI in such advanced.
I said for pigment dispersion, it will be concave.
Yeah. No, yeah, you said that. So although DD is, always when there's a pigmentation in the eye, we have heard a lot about Bade and Badi syndrome, which, we came to know about these terms during COVID time. So do you know about those terms? Because in exams, I think DD will be asked of all pigmentary changes in the eye. So have you heard about that?
Yes, ma'am. Most commonly associated with antibiotic usage like moxifloxacin, it can occur, ma'am. Bilateral iris dispersion or iris transillumination defects can occur.
Pigment dispersion.
Yes.
Yes.
Yeah, Badi and Bate.
Yeah.
Separate, but maybe quite related. We don't know.
Yes. So
I have a questions.
Yeah.
So, I mean, what will be the angle features in the pseudoexfoliation glaucoma? Will it be open angle or angle feature?
It can present as both. Mostly it's open angle. The patient will have patchy trabecular meshwork pigmentation, and a Sampolis line can also be present. A pigmentation which is present anterior to the Schwabi's line can be present, and in around 14 to 43%, it can present as a closed angle also.
So, how will you differentiate from PSCG?
Presence of pseudoexfoliative material will be an additional point. Gonioscopy to differentiate.
Yeah, and any other clue from fellow eye perspective, like
flaky material, any pseudoexfoliation material deposition in the other eye, poor miotic pupil, poor dilatation of the pupil.
Is bilateral pseudoexfoliation common?
No, ma'am. Initially, it presents as unilateral and then progresses to bilateral presentation usually.
So that is what he's trying to tell you. That if it is purely pseudoexfoliative angle closure, you may not see pseudoexfoliation in the fellow eye. Or quite often they might be, pseudophakic also, in which case it might become difficult to.
Okay.
Yeah, he was trying to ask you, primary angle closure versus pseudoexfoliation angle closure, will it be possible for you to differentiate? Yes, if you have in a primary, both eyes will be almost kind of symmetrical, but not necessarily always. But in pseudoexfoliation, in one eye, very dominant. And if you have an angle closure, the other eye is normal, then it is most likely because of the pseudoexfoliation secondary.
Okay, sir.
It's a very thin margin, but it is many times we can really say that is it because of the exfoliation or because of the primary.
So they also overlap, like.
Good.
Yeah, they can overlap.
Overall,
Sure,
very good presentation.
Thank you, sir.
Any more questions from the judges?
It's okay.
Probably they had more questions than their exams.
All right. It's a wonderful experience for them, ma'ams and sirs. I mean, they are getting to hear from the experts of glaucoma, and this is going to be a simulation of what your vivas are going to be like. So, great work. Can we have the third team share the screen now? This is Synergist Squad, Team 3.
Is my size visible, ma'am? Hello?
Is your first slide is Synergist Squad in black and red?
Yes, ma'am. Yes.
Yes, that's your slide. It's visible. It's visible.
Okay. Can I start, ma'am?
Yes, please.
A warm good afternoon to one and all present here. Let's do a case scenario. A 30-year-old male patient came with the complaints of left eye pain for the past 2 days with a mild photophobia and mild redness. On examination, right eye is normal, left eye is left eye vision is 6/9, IOP is very high, and there is mild corneal edema with fine KPs, mild AC reaction, and there is a normal fundus, and the gonio it is open angle. There is the patient had a similar milder episodes in the past, which recover on its own. The most probable diagnosis is Posner-Schlossman syndrome. In order to know this disease, let's go back to 1948, on which Posner-Schlossman described a patient with a recurrent unilateral ocular hypertension, iritis, few KPs with which resolved once the IOP is normalized. This sparked the interest in the link between the glaucoma and the cyclitis. It is also known as glaucomatous-cyclitic crisis due to its acute condition. It is also common in 20 to 50 years of age. It has male predominance. It is considered as a self-limiting and benign condition. It is characterized as recurrent, unilateral, acute, mild, non-granulomatous anterior uveitis with elevated intraocular pressure. On the long run, it may cause a chronic secondary inflammatory glaucoma. Etiology. Even now, the etiology is still debatable, but the most commonly accepted is infectious theory. With the cytomegalovirus, herpes simplex virus, varicella zoster virus, and Helicobacter pylori. Other theories include autonomic dysfunctions, allergy, autoimmune, which is prostaglandin-mediated vascular endothelial dysfunction. Coming to pathophysiology, here, normally the aqueous produced in the ciliary process travel through the pupil and drain through the trabeculum. In PSS, there is a blockage of aqueous outflow due to the clogging of trabeculum by the inflammatory cells, causing increase in intraocular pressure. There may be a thickening of trabeculum too. Histopathology. This shows an electron microscopy of a trabeculum with mononuclear cells with long pseudopods occluding the trabeculum. Clinical symptoms include mild discomfort, slight blurred vision, white eye, or mild congestion. In intensity, it can cause halos. Clinical signs include increased intraocular pressure, mild circumcorneal congestion, epithelial edema, fine discrete KPs, AC reaction, surface pupil. There is this normal optic disc with normal visual field in the initial stage and open angles on gonio. The crisis may last from several hours to weeks. Normal in between the attacks, there is IOP is normal and there is no signs of uveitis. On investigations include tonometry, central visual field, optic nerve head, and retinal nerve fiber layer tomography, iris angiography, PCR analysis of aqueous tumor tab in case of viral origin, confocal scanning microscopy. So it's a coin-shaped CMB. Management. The main goal of the management is to reduce the intraocular pressure and to control the inflammation. The medical management include reducing IOP by anti-glaucoma drugs like beta blockers, alpha agonist, carbonic anhydrate inhibitors. Pilocarpine is avoided in such cases as it exacerbates trabeculitis. Control inflammation by topical steroids like prednisolone, dexamethasone, and NSAIDs. And nowadays, it is proved that the antiviral therapy also improve the in case of viral origin. Surgical treatment, filtration surgeries like mitomycin C and trabeculectomy. Differential diagnosis include acute and chronic angle closure glaucoma, ocular hypertension, primary open angle glaucoma, uveitic glaucoma, Fuchs heterotopic iridocyclitis, herpetic iridocyclitis. Complication includes glaucomatous optic-disc, RNFL defect, NON, optic atrophy, corneal endothelial insufficient, and ethelitis. Thank you.
Nice presentation and very crisp. So I have one or two questions.
Yes, ma'am.
As you have mentioned also, it is a rare, unilateral disorder.
Yes, ma'am.
And how does it differ from, because the diagnosis is very tricky and, we are sometimes, one can miss the diagnosis. So what are the other DDs? You have already talked about it, but can you just explain in detail how do you
Yes.
differentiate it from other differential diagnosis? Because it's sometimes, the diagnosis is very difficult.
Yes, ma'am. It can be differentiated from angle closure glaucoma by there is it is closed angle on gonio, and there will be presence of peripheral anterior synechiae in angle closure. In primary open angle glaucoma, there will be persistent increased IOP without resolution. There will be no signs of
Is that a
such
DD? POAG is a DD of Posner-Schlossman? Like, what is the main differentiating features between the two?
It is open angle, ma'am. Then there is no inflammation reaction in the primary open angle glaucoma. And
What else is important, doctor, in that?
What that, yeah.
KP is
POAG,
also and uveitic reaction.
POAG versus Posner-Schlossman.
There will be no uveitic signs, ma'am.
Unilateral or bilateral?
Yeah. Then
yeah.
Sorry.
No problem. No problem.
Yes.
It's bilateral.
And what about the pressure, intraocular pressure?
This
POAG versus Posner-Schlossman.
In Posner-Schlossman syndrome, during the attacks, the IOP is elevated very high, like 40 to 50.
Yes.
But in POAG, it is remained same without any resolution. There is no.
So what is the really patient? The patients will be very symptomatic.
Yes.
PS syndrome, the patient will be symptomatic. POAG, they will never come with the symptom. Mostly, you diagnose POAG.
Yes, sir.
PS, they come with some problems.
Yes, sir.
Yeah. Yes, please.
Then uveitic glaucoma, in that there will be intense AC reactions will be present. Here it is very mild reactions. And Fuchs iridocyclitis, in that case, it is also unilateral. In that there will be iris atrophy will be present, diffuse iris atrophy, and the erythrochromic iris will be present. Then cataract, angle vessels, fragile fine angle vessels will be present.
Mainly Fuchs, doctor, two important things you must say, three things. Okay.
Yes,
about the capes, what type of a capes you have,
diffuse
what is the
capes will be
angle,
present in
what is the angle, and then what about the iris, how do you really describe the iris? These are the three important things you must clearly say.
Kind of KPs are present.
Yes,
diffuse in Fuchs.
Nice.
I have a few questions for you.
Yes.
Firstly, you put tonometry as an investigation. Is it an investigation?
It's not, like, it is one of the tests we are doing, so I included in that.
Clinical examination. You have to be very clear what is a clinical examination and
Yes,
what is an investigation.
Yes, ma'am, sure.
Amongst the investigations you have listed, have you known any one of these to be done?
Like
other than tonometry, which is not an investigation.
Yes, ma'am. We usually do like ONH tomography and central visual field in order to see any optic disc damage is there. In long-term course, there will be signs of damage. In case if we suspect viral, there will be we can do PCR analysis of aqueous tap for viral
Yield a
etiology.
negative result. Anyway, that's beside the point. So why do you think they get halos when they present?
Halos, tell me because of a mild corneal edema, there is a refracting then there will be because of the AC
Why
reaction.
do you get corneal edema in Posner-Schlossman at a pressure of say 45, and open angle glaucoma or pseudoexfoliation glaucoma, you may get pressure of 45, but you
Yes,
don't
ma'am.
get corneal edema. Do you know why?
That is very important for you to know. Yeah.
Yes, because of clogging of trabeculum, there will be no outflow. Endothelium pump damage.
What is the presentation of Posner-Schlossman? It is relatively
mild.
Not mild.
Like
acute.
Acute presentation with mild symptoms.
You have said everything, but you have gone through your points very mechanically. You have said everything.
Yes, sir.
You know the reason why. So it's an acute present. Sudden acute rise of pressure will give you microcystic corneal
epithelial edema.
but slow rise as in POAG or PXFG or any other glaucoma, it will not give. Okay. So it is the sudden acute rise that is more dangerous than an eye which has had time for adaptation to the pressure over a period of time. When we say danger means what we are worried about with a high pressure, what are we worried about with a high pressure? What happens to the retina? What happens to the retinal vessels?
There be ischemia maybe happen.
She has already given you the answer. She has mentioned about retina, vessel, everything.
What pressure can you occlude the vein, retinal vein?
She gave you full diagnosis.
Like a sudden increase in the intraocular pressure. Like
to what level?
Like 40 to 43.
Okay, 40 will, but anything above 30 is dangerous. Sudden acute rise. Okay. If you have a period of adaptation, that may not happen. Okay, because you have autoregulation in the retinal vasculature.
Yes, ma'am.
At what level will you occlude the retinal artery, central retinal artery? Or you can occlude, and you have to bring the pressure down, IOP down rapidly.
If it is more than 50.
Correct. Yes.
50.
So 30 is for vein, 50 is for
artery.
Artery, yes. Okay.
I hope all other people are also listening to this. No, it is a very important point. Acute spikes, what happens, and chronically elevated IOPs, what really happens. This all of you should know. It's not only for exams, it's for lifetime understanding.
Yes,
yeah.
Yes, sir.
And the other thing I wanted to say, when would you actually operate in Posner-Schlossman? When it becomes chronic and you have, say, maybe a conversion into intermittent angle closure, or in the acute phase?
We don't do surgery in the acute phase, ma'am. We first reduce the intraocular pressure as much as possible and control the inflammation. Then if at all we first control, then if that in medical management, if there is if it is the IOP is not controlled, then we will go to filtration surgeries.
So one of your first few slides said it is a benign self-limiting.
It was considered as a self-limiting and benign condition.
Okay. Anything you say in glaucoma, you think about it 10 times. Okay, because at the end of the day, it can become a chronic condition.
Yes,
and yes, each episode in the beginning might resolve.
Yes,
but you can continue on and develop a chronic condition.
Yeah. Yes, ma'am.
Good.
Let me ask you one.
Thank you.
Yeah, one last question. So how do you choose this case to present? I think this is one of the most difficult case, and
Yes, sir.
obviously
I'll
rare, and
take the
most
part.
of the answers.
They did not choose the case. They were allotted cases. So we had an angle closure as well. And that
She's the most
team.
unlucky one. But she has really answered well. And I
Yeah.
guess to answer all of I can give you a clue to answer questions like this. So just your first answer should be, it is rare and idiopathic. So most
Okay,
of the answers should be like that.
Okay, sir.
You do not know.
Okay, sir.
Thank you so much, judges. And thank you, team 3. You,
Ma'am,
your
we are
mentor
going
is here?
to, yes, ma'am.
Absolutely. Can we have ma'am?
Yeah, I welcome my mentor, Dr. Kausalya ma'am, Department of Neuro-Ophthalmology, Aravind Hospital, Madurai. Over to you, ma'am. Ma'am, you're in, you have to unmute, ma'am.
Varshalya ma'am, please unmute yourself.
Madam, we can't hear you.
Ma'am, please unmute yourself.
No, I don't think it's working.
Uh,
Please thank her on our behalf.
Thank you so much, ma'am. We can take your comments after the 4th team. Your mic is not unmuted. Can we have the last team for the seminar presentation, please? The Illuminati. Can you start screen sharing?
Yes, ma'am.
Thank you, judges, for a wonderful question answer round for team 3. I'm sure all the participants and all of us also got to learn a lot.
I am keenly observing and definitely learning something.
Ma'am, is my screen visible?
Yes, your screen is visible.
And am I audible, ma'am?
Yes, you're audible.
Right, ma'am.
Your time starts now.
A very good afternoon to all. At the outset, I would like to thank the YOSI fraternity for providing us this wonderful opportunity. Topic of seminar is angle recession glaucoma. So there are 3 types of muscles in the ciliary body: the longitudinal muscles, the oblique muscles, and the circular fibers. So angle recession is separation between the longitudinal and circular muscle fibers. So this is a short video depicting the ocular trauma to the eye. Following which, angle recession is seen in most of the cases. The proposed mechanism behind this is the blunt trauma forces the aqueous humor against the iris and angle laterally and posteriorly. This exerts a traction on the iris root, leading to a tear between the longitudinal muscles and the circular muscles, which further damages the trabecular meshwork and Schlemm's canal, causing an early IOP spike. Later on, scarring and fibrosis of trabecular meshwork occurs, which leads to elevated pressure and thus causing secondary open angle glaucoma. There are 2 other mechanisms also: the loss of tension of ciliary muscle on the ciliary scleral spur, thus narrowing the Schlemm's canal, and a hyaline membrane can also grow across the trabecular meshwork, thus obstructing the aqueous outflow. So these are the 7 rings of ocular trauma as given by Campbell. We can see the angle recession in the 3rd ring. A small percentage of cases go on to develop glaucomatous optic neuropathy and vision loss later on in their life. It represents a bimodal pattern, with glaucoma occurring either within the first year or after 10 years. There have been reports which have showed that glaucoma can develop even up to 50 years after the injury. It is important to note that 50% of angle recession glaucoma patients can develop glaucoma in the fellow eye also. Angle recession per se does not always lead to glaucoma. Approximately 3 to 6% of the cases develop angle recession glaucoma. And there are various other risk factors also which are responsible for it, like presence of increased pigmentation at the angle, elevated baseline IOP, hyphema, or lens displacement. Greater the number of clock hours of angle recession, greater is the likelihood of glaucoma development. So during slit lamp examination, we must look for evidences of ocular trauma. The traumatic hyphema, it is strongly associated with angle recession with an incidence of 60 to 100% cases. So gonioscopy should be performed every year in such cases. Gonioscopy is critical in establishing the diagnosis of angle recession glaucoma. This is the normal angle showing all the four structures. And this is a picture showing the angle recession in a ARG patient, showing irregular widening of the ciliary body band with posterior displacement of the iris root. The differentials generally applies to open angle unilateral glaucoma. For example, unilateral steroid use, pseudoexfoliation glaucoma, pigmentary glaucoma, uveitis glaucoma hyphema syndrome, or caroticocavernous fistula. The treatment is on similar lines as an open angle glaucoma. We can use topical aqueous suppressants like beta blockers, carbonic anhydrase inhibitors, or alpha agonist. Prostaglandin analogs should be avoided in acute phase as they are pro-inflammatory. But once the acute phase is over, we can use it as they bypasses the trabecular meshwork. Pilocarpine should be avoided as they exacerbate the angle recession, and cycloplegics are to be used in cases of pupillary block. If the medical therapy fails, laser trabeculoplasty can be tried if the initial IOP is not too high, but they does not have a high success rate. Filtration surgery is certainly an option in these patients, provided the conjunctiva is not extensively scarred. We have two options here, trabeculectomy without antimetabolite and trabeculectomy with antimetabolite. The later one is found to be more effective. Then comes the glaucoma drainage devices, which have some benefit. However, the success rates are lower. There has been Molteno implant, which was found to be successful in a prospective case series. And in an eye with limited visual potential, we can try cyclodestructive procedures also. So angle recession glaucoma are more difficult to control both medically as well as surgically than the other types of glaucomas. Hence, adequate counseling and regular follow-up of the patient is required. Thank you.
Thank you, Team 3. Moving on to the judges' questions, please. They were well in time.
I think it's a very common, cause. Trauma is a very common cause of secondary glaucoma. And I'm very sure that it is one of the most commonly presented case for the exams also. So how do you differentiate between a traumatic glaucoma, which occurs in the early stages, vis-a-vis, how do you say it is because of angle recession or it's a traumatic glaucoma? What are the differentiating features? You have already told us the gonioscopy findings and all, but in terms of timings and the extent of trauma, how do you differentiate?
Traumatic glaucoma will present early. However, angle recession can occur within the first year or after 10 years or even up to 50 years of the injury. So we have to perform gonioscopy to look for angle recession in these cases. And
when you perform gonioscopy in a patient with trauma?
Ma'am, after 3 to 6 weeks.
Why?
Ma'am, because initially if we do the gonioscopy, it itself can damages the trabecular meshwork, further causing raised IOP.
And you also said in your slides that if there's a hyphema, then there's increased risk of angle recession. So why you say that? Even if it's a minor hyphema, like what should be the extent of hyphema?
Ma'am, there have been studies which have showed that traumatic hyphema is strongly associated with angle recession glaucoma.
But how much hyphema? If it is just a little bit of blood which is dispersed, vis-a-vis it's a full chamber hyphema, like what is the relation between...
Even if it is less, ma'am, the chances of angle recession glaucoma are more.
Is it so?
Ma'am, I have seen
it depends on the extent of angle recession.
Yes, ma'am.
Okay, so what does it signify? The extent of angle recession, what does it signify? If it is 90 degrees or 100 degrees?
Ma'am, more than 180 degrees, some studies have shown, and more than 180 to 240 degrees of angle recession, higher is the chances of development of glaucoma.
So basically, angle recession, if it is more, it shows that the extent of trauma or the blunt trauma was much more.
More, yes, ma'am.
Yeah, the severity was much more. That is why the patient has developed if there's a little bit of blood and minor uveitis and less than 90 degrees of angle recession, the patient may not develop. So I don't know. I'm not aware of any studies which other judges can comment.
There is I failed to remember the paper exact authors now, but there is a study which quotes 10% glaucoma over 10 years when you have 360-degree angle recession. Okay. So obviously, the greater the extent of angle recession, the greater the chance that the patient may develop. And how would you counsel a patient who only has angle recession at the moment? They're young people. It generally happens in sportsmen or, young men.
Yes,
Where it occurs much more commonly. How do you impress upon them that they need to come back, not just for gonioscopy? What else?
For IOP monitoring, ma'am?
Exactly, IOP monitoring. Because obviously they will not be able to say when the pressure goes up.
Yes, ma'am.
All right, so it has to be picked up by the treating ophthalmologist. So how would you counsel a patient like that?
Ma'am, we'll counsel him or her to come every year for IOP monitoring, for gonioscopy.
360-degree, you would still say every year?
No, ma'am. 360-degree is every month or
Every month.
Nobody will come.
or every 3 months, ma'am.
6 months is fine. Okay. 6 months is fine. Basically, you have to tell them what may happen if they do not get their pressures checked. Okay.
Yes,
if you
ma'am.
don't say you have to come back for your pressure check.
No, ma'am. Yes, ma'am.
Why? Nothing is wrong with my eye. I don't feel anything. Why should I come? So they need to know what is the end damage, what it can do.
Yes, ma'am.
That's how you counsel a patient, and that's when they come back. Otherwise, they don't come back. Okay.
Okay.
Sorry. One more question.
Yeah.
Have you heard of MIGS?
Yes, ma'am.
Do you think
Micro
there's any
invasive.
role of MIGS in angle recession glaucoma?
Yes, ma'am. MIGS have played an important role. This is micro-invasive glaucoma surgery devices, which includes, ma'am,
It's not just devices. It's not just devices. You have procedures as well. But
right, ma'am.
What do you think could help here?
Ma'am, by placing the eye stent or eye stent adjunct, we can bypass the trabecular meshwork and increase the aqueous outflow, thus reducing the IOP and the chances of development of angle recession
Do
glaucoma.
you think the excess pigment that you have will not block? Cannot block?
It can.
Huh? Which other MIGS do you know that may help?
So,
Your team members could answer. Any idea?
ma'am, Zengel stent.
Ma'am, subconjunctival Zengel stent or
Okay, not available in our country. That is sort of MIGS plus or a minimally invasive bleb surgery, as it's called now. No longer part of MIGS. What do you think? Where is the problem? Where is the seat of the problem?
trabecular meshwork.
Trabecular meshwork. So if you unroof the Schlemm's canal, take the trabecular meshwork away, will it work?
Yes, ma'am.
Yes, ma'am.
Huh? So what is that procedure?
That is SLT, ma'am, like extended
laser. Have you heard of Bang or Kahoot dual blade?
Yes, ma'am.
Yes,
Dual.
Yeah?
yes, ma'am. Yes, ma'am.
Yes, ma'am.
So if there is a mixed procedure that might help, it is definitely that. Actually, nowadays I tend to do that only.
Right, ma'am.
Rather than jump to trabeculectomy.
Right, ma'am.
Okay. So you will have a small clue based on the IOP in a traumatic glaucomas. Say, for example, you have hypema, you have a very low IOP. Okay. So does this give you a clue?
Yes.
Yes, sir.
Of how these patients will be proceeding in with their disease? Low IOP.
So low IOP can be there because of cyclodialysis, cleft.
Sir, if it's a case of low IOP, we might think on lines of uveitis, sir, because it can be a glaucoma secondary to uveitis, sir, because in that cases, in acute phases, we usually have a hypotenuse eye, sir. So we might think on those lines, sir. We might think of
Okay. So it is better to understand a little. So when you have a very low IOP in a traumatic glaucoma, one, definitely yes, you need to look at the cyclodialysis cleft.
Right.
But sometimes they have a shock.
Acute phase
And
of the shock.
yeah, okay. So these patients, you must be very closely watching them. They will come back with a very high IOPs very soon. So these are the patients, sometimes you will be finding it very difficult to treat. IOPs will be really very high. Okay, so that will give you a clue. That is one thing. And regarding the gonioscopy, you said about 4 to 6 weeks.
Yes,
That's, I think, is too long a period for you to wait for a gonioscopy. You must be aware of one is with the gel, you keep the gonio lenses, and without, no. So indentation you can do without much of a difficulty. So gonioscopy, you don't have to really wait for 6 weeks. 4 to 6 weeks is too long a period. The other clue for you is whenever you are asking the patient to come, say, for example, once in a year or 6 months, what is that one clue you can have is you have to keep writing the pressures for that particular patient and see how much is the fluctuation that the patient has got.
Right.
Say this time the patient has come with a 13, next time also 13, 14, in that range. They are reasonably okay. We are not saying that you are not having anything. But once from 13, when the patient comes back to you next visit with 18, then you need to watch them much more closely. Okay. So that will give you a clue of when or how often you should possibly calling the patient for a follow-up. Okay.
Right, sir.
Yeah.
I want to share with you a very interesting case of a medical student who first came to me with angle recession glaucoma that became pretty advanced. And by the time he came to me, I had to do not controlled. I had to do a TRAB at that time. KDB and all did not exist in our country. And whilst he was finishing his MBBS, he got another trauma. And this time he got cyclodialysis cleft. So he had developed choroidals, very low IOP. He came back to me here in Hyderabad. I did, fortunately, it was not too much of a cleft. I just did argon laser. It went and stuck, and he's now 6/6 vision without any medication. He's very happy. But
Yeah,
so it
sometimes,
can,
sometimes the trauma helps them.
yes. So
Yeah,
it
I
was,
just
it
have
was lightning struck twice in the form of blunt trauma with two different manifestations of blunt trauma.
Yeah, in the presentation you mentioned about 2 percentages. Like one was the 6% was the incidence of glaucoma from angle recession.
Yes.
And another was 60% the incidence of recession in hypema.
Yes, sir.
So can you elaborate? There will be obviously range, but obviously the fact is that there will be higher incidence of angle recession if there is hypema and much lower incidence of glaucoma from angle recession. So
Yes,
can you
sir.
elaborate on this
Sir,
sentence?
angle recession alone does not always lead to glaucoma. There are other factors which have not yet been discovered. Few of the factors are like because of lens dislocation, presence of pigmentation, or an already at-risk eye or the high baseline IOP. So these are the factors which also contribute for development of glaucoma in later part of life. And there have been studies which showed that 3 to 6% of the cases develop angle recession glaucoma following a trauma. And if there is traumatic hyphema, the chances are more, sir, almost 60 to 100%
Exactly.
incidence.
So that's a point that you need to carry, convey to the parents if any children come with the same problem, that the trauma. So only subtle trauma, obviously, there is very less chance of future development of glaucoma unless there's hyphema. If there's a hyphema, there will be more chance of hidden recession when it will be visible after the hem resolves. And if there is recession, correspondingly, the incidence of glaucoma will also be there, but a bit less. There's also another percentage that you mentioned, that some 10% cases there will be a other eye can also develop glaucoma.
50%, yes,
So
sir.
yeah, can you explain that? How
So
it is possible?
50% of the cases can develop glaucoma in the other eye also.
Okay, how it is possible? So we are dealing with a secondary situation, no? Traumatic glaucoma, traumatic angle decision. So how is the other eye is connected to it?
More so in cases
Any
of
idea?
at-risk eye,
Have
yes.
you ever imagined that this angle recession is happening in only open angle eyes?
Yes.
So have you ever seen a patient with angle closure? That in India there are so many patients who have shallow AC and angle closure, PACS, very high prevalence. So those patients, they can also have trauma, no?
Yes,
Yes,
sir.
But after trauma, do they develop any angle recession?
No, sir.
No, sir.
So even if they are developing, they are
We
experiencing
will not
trauma,
be
maybe.
able to detect, yes.
So the
sir.
eyes which are prone to eyes which are open angled,
Sir.
they will be further opened up after trauma, and angle recession is happening for them. And these are the eyes, actually, they also have a genetically higher predisposition for steroid response. So that is also one fact that to be kept in open. So whenever you're treating these patients with hyphema, with steroids and other things, so they say also chances of ipsilateral, contralateral IP spikes, so from steroids. So there's also overlap between steroid response and angle decision.
Right, sir.
So
Abhi,
just to
I never-
elaborate this point more, I think very rightly said, the other eye is also predisposed. And we have seen, and it's mentioned in literature also, that myopic eyes are more prone for
Yes.
angle recession and hypermetropic eyes are more prone for anterior subluxation of the lens. Okay, that we have
But-
seen.
but
So
I
whenever
never
there's a
seen
blunt trauma, if it is hypermetropic, they will not develop angle recession. But if it's a myopic eye, there are more chances of developing angle recession.
Yeah, but I never say never in medicine. I have a patient who
Yeah,
had
it can happen,
angle
but
closure both eyes. Obviously, because
Yeah.
but one eye was open because he had angle recession.
yeah,
However,
can happen.
the
Yeah.
the entry into the angle was very steep, very acute, and when you saw through, you could see angle recession in the eye, which had trauma. So it's not that it can't happen. It
It
can.
can't happen.
that's
It's
why
not. It's never there
experience
that it
counts.
can't happen. But it generally, like the picture is
But
like that.
this is what
Yeah.
years of glaucoma
Yeah.
tells me, that
But I have seen, like in my experience, mostly the patients are myopic and the other eye is also predisposed. So I think that's very important that you follow up the other eye also, just not the eye which is affected.
Yeah.
Okay.
Thank you, guys.
Thank
Well
you.
Thank you, ma'am. Ma'am, in the end, I would like to welcome my mentor, ma'am, Dr. Colonel Vijay Kumar Sharma. He is a cornea and refractive surgeon here at AFMC. Sir has also joined, ma'am.
Yeah, good afternoon, everyone. I think it was a wonderful initiative by the team YOSI to give a good platform to all the residents to present cases and also getting sensitized to these very, very important topics that have been selected. And also very thanks to the judges for subjecting them and giving them a first-hand experience about Viva, how it goes about on a topic. This will give them insights into how they should be reading about the topics. So thank you very much. And hello, Arshi. Hi. It's always very great to be associated with any YOSI platform, being the founder president of YOSI. So thank you very much. Thanks a lot.
Great.
Pleasure to have you here, sir. And
Thank
thank you to all our judges for a wonderful first round. Again, without wasting time, let's move on to the second session. So I'll invite Dr. Neelam to start the second session for all of us. Good afternoon, everyone. So we would start our second session, that is Pupils Got Talent, in which the members of all the teams have made some creative videos. So we will be playing one by one. So I request Dr. Ashi to play the video by Team 1, that is Vitreous Vanguards.
क्यों कर लिया ट्रीट तुमने ग्लूकोमा को? मुझे तो नहीं लगता, मैं तो बढ़ रहा हूँ। जहाँ देखो वहाँ लोग अंधे हो रहे हैं मेरे कारण। मरीज को तो पता ही नहीं होता कि उसे कांचबंद है। क्या इसे पता लगाने की कोई तकनीक है तुम्हारे पास?
हमारे पास बहुत सारे तरीके हैं जिनसे कि हम पता लगा सकते हैं कि मरीज को ग्लूकोमा है या नहीं, और अगर है तो वो कितना बढ़ गया है। हम मरीज के आँख के प्रेशर की जांच कर सकते हैं, उसके पर्दे की जांच कर सकते हैं, उसके आँख की नस की जांच कर सकते हैं और उसके विजुअल फील्ड की भी जांच कर सकते हैं। और तो और उसे किस प्रकार का ग्लूकोमा है ये पता लगाने के लिए हम गोनियोस्कोपी द्वारा उसके एंगल की भी जांच कर सकते हैं।
अच्छा, मान लो तुमने पता लगा भी लिया, तो क्या इसका कोई इलाज है तुम्हारे पास?
हमारे पास तरह तरह की ड्रॉप्स भी हैं जो मरीज आँख में डाल सकता है, और तो और खाने के लिए गोलियां भी हैं।
तुम्हें क्या लगता है, तुमने पेशेंट को ड्रॉप्स दे भी दी तो भी मैं 5-10 दिन में ठीक होने वाली बीमारी थोड़ी ना हूँ। मुझे बढ़ने से रोकने के लिए सालों तक ड्रॉप्स डालनी पड़ती हैं।
मरीज को सिर्फ ड्रॉप्स देते नहीं है, उसे काउंसिल भी करते हैं कि उसको ये ड्रॉप्स क्यों डालना है और ड्रॉप्स ना डालने से क्या दुष्परिणाम हो सकते हैं, उसकी आँख की रोशनी तक जा सकती है। और तो और हम उसे रेगुलर फॉलोअप में आने की सलाह भी देते हैं।
चलो मान लो मैं एक ड्रॉप से ठीक नहीं हुआ, फिर क्या करोगे तुम?
हाँ, तो 1 से भले 2, 2 से भले 3 और 3 से भले 4।
इतनी ड्रॉप्स दोगे? साइड इफेक्ट्स हो गए तो? और मान लो प्रेशर भी कंट्रोल नहीं हो पाया, फिर क्या करोगे?
उसके लिए हमारे पास तरह तरह की सर्जरीज भी हैं।
क्यों?
So this was an interesting video by Team 1 Vitreous Vanguards on the awareness of glaucoma. I request now all the judges to share their views on the reel, and they can put the marks on the Excel sheet given to them. Judges, any comments or any questions to Vitreous Vanguards about the glaucoma awareness video that they've created?
Nah, nothing much, RC. It's okay. I mean,
I think we can play all the videos and we can mark. I think there are no questions.
All right, ma'am. So now the second video is by Team 2, that is Vision Virtuosos. I request Dr. Ashi to play the video.
This is a surgical video demonstrating the challenges faced during cataract surgery in a patient with pseudoexfoliation. To overcome these challenges, various measures can be taken. To protect the cornea, dispersive OVDs like viscoat can be used. In case of a small pupil, pupil expanders can be used, MST can be done, or a stretch pupilloplasty can also be done. Viscodilatation with cohesive OVDs can also be used. To decrease the stress on the zonules, CTR and capsular hooks can be used. And to decrease the post-op inflammation, heparin surface modified intraocular lens can be used.
So this was the video by team 2 on pseudoexfoliation. Now I request Dr. Ashi to play a video by team 3, Sinus Squad. Okay, now we will have a video from team 4, the Illuminati.
लेफ्ट आई में कांच दोनों में ही था, पर लेफ्ट आई में पूरी रोशनी कम हो गई।
ग्लोकोमा यानी काला मोतिया या गाज बिंदु, ये आंख का बीमारी चाहते हो क्या है इसके बारे में जानना चाहते हैं। ठीक है, चलो बताते हैं।
हमारा जो हड्डी होता है वो तो बढ़ता नहीं है, हड्डी उतना का उतना ही है, पर जो प्रेशर है उसकी वजह से जो टिश्यू है वो बढ़ता जाता है और पीछे की नस को सुखाता जाता है, तो जिसकी वजह से आपकी देखने की शक्ति कम हो जाती है। ठीक है, तो इसलिए हमेशा क्या करना है, जो भी 40 साल से ऊपर है, ठीक है, उनमें ये रिस्क ज्यादा होता है। दूसरा, या तो जिनकी फैमिली हिस्ट्री में ग्लॉकोमा है और कोई चोट लग जाना, उसमें ग्लॉकोमा के चांसेस ज्यादा होते हैं। ठीक है, रूटीन चेकअप कराना है। अगर आप 40 साल से ऊपर हैं तो एक प्रेशर चेक कराते हैं, जो कि हमारे। दूसरी चीज होती है पीछे की नस का इमेजिंग, में ओसीटी है, ओसीटी आरएनएफएल बोलते हैं, उसमें है, तो आपको टाइमली इसमें क्या है ड्रॉप डालने होते हैं। तो वो कंप्लायंस जो होता है कि पेशेंट डाले, हम तो बता सकते हैं, आपको खुद से डालना होता है, तो वो आपकी जिम्मेदारी है। अगर वो पेशेंट को हमने बता दिया और उसने डाला नहीं तो ग्लॉकोमा ट्रीट नहीं होगा, उसका प्रेशर बढ़ा रहेगा और उसकी नस सूखती रहेगी। ठीक है, और फिर वो दिखने में धीरे धीरे कम हो जाएगा। तो प्रेशर कंट्रोल नहीं होता, उसमें सर्जरी करते हैं। ठीक है, तो वो हम बताते हैं, फिर आपको फॉलोअप पे आना पड़ता है, आपका विजुअल फील्ड टेस्ट होता है, प्रेशर चेक होता है, तो उसके लिए आपको हर महीने, हर 3 महीने या हर 6 महीने वो हम पेशेंट को बताते हैं, उस तरीके से आपको आना होगा।
ये बड़ी अच्छी बात कही है।
So this was all. These were the creative reels from all the 4 teams. I would request judges to share their views and comments on the creative side of the residents.
I think the videos which were made by the residents themselves were looking quite impactful for creating awareness to the patient, especially, when they're talking to the group of the patient, creating awareness like what is glaucoma and how can you detect it early. I think this is very, very important, and we should keep creating awareness. Unfortunately, it is being done only during World Glaucoma Week. Every time we feel that it should be done on a periodic basis so that patients understand about their disease and, they come understand and then they come for follow-up and they themselves can create awareness. So I think those kind of videos are quite promising and impactful. So I think we should keep doing that, all the institutes at least.
Yes, ma'am. Vanita, ma'am, please. Dr. Satyan, sir.
Yeah. Actually, it's a wonderful presentations from all the team. I mean, what to say? If they can understand the themes little bit better, so think about what is that you wish to, like see, and what can impact you. When somebody says, okay, you check up for glaucoma, how you can really create an impactful things. So that gives you a clue of how you can make your videos. So the third one, I'm not able to recollect the presenter. That is on the PXF was nice. So something like that, very impactful, clear pictures. So that can give you a good, impactful videos. And the third one was also good from the
Third one
synergist.
was Synergist Sword, sir, and fourth is
Yes.
Illuminati.
Okay, I'm just getting confused, I think. So anyway, all of them had their own creativity that is quite good actually. So just to say that we are going to have our flyers soon on. We want all of you to make reels on glaucoma awareness for the World Glaucoma Week. From GSI, we will announce the winners once we receive all the reels. Tomorrow or day after tomorrow, we'll send the reels. So all of you can make good reels. It is not just the video. You have to make clear-cut reels. You go to YouTube and see how the reels are made. So you can create reels and send. I'll send the flyers soon. So thanks, Asif, for this opportunity here. And all the YOSI
to
team.
have
I
you
won't
all.
thank you alone, but I think the entire YOSI team has taken a big step. Superb.
The entire team has been working really hard, and I think a lot of credit goes to the participants who've taken a chance to be here. It's not easy to be on a platform where you have to answer questions, but it's so wonderful that you all are taking this chance and using it to the maximum potential.
Absolutely. They all did a great job, actually.
I want to thank all of you judges and mentors for being here. Thank you, Sunita ma'am. Thank you, Vanita ma'am. Thank you, Satyan sir. Thank you so much, Avik sir, for being here today. And if I may, I would like to present your certificates to you before you decide to leave. You would be welcome, more than welcome to stay for the next 2 rounds. But we understand that you had time is very important. And so next
Very fancy certificate, Asif.
Thank you so much, ma'am and sir.
Thank you.
Thank you.
Thank you. Thank you.
We will send you the sheet also, no?
Yes, ma'am. Please share the Excel
email
sheets with me.
Okay.
Yes, email or WhatsApp, and I
Okay.
will compile them
Sure.
thereafter.
Oh, thank you.
Thank you so much.
Bye-bye.
Thank you.
To all
Good
the
luck.
mentors
Bye.
as well.
Good luck to them.
Ma'am, wait, please. Before you leave, let us all switch our screens, videos on so we can have a picture. That'd be great. I hope no one's left. Yes, you're all here. Oh, perfect. Mr. Sai, can you help us with taking a picture, please?
Not all are on online yet.
Yes, all right. Synergist, vision vitreosis, please, virtuosis, sorry. And all the audience, please, if you could, it'll be wonderful to see you guys as well. Synergist, we're waiting for you. Okay, I think we'll go. 1, 2, 3. I think we got a good picture. Thank you so much.
Okay, thank you. Bye-bye.
Thank you.
Thanks for inviting and great job, all teams.
Yeah.
Thank you.
Thanks.
So teams, we'll move ahead with the third round now. Dr. Moshmi will be taking up the lead on this. Dr. Moshmi, I'll just start my screen share.
Sure. So congratulations, everyone. And following the impressive presentations by the postgraduate students and the enlightening discussion which we had from our esteemed glaucoma specialists, we'll now move on to our next round, which is known as the knowledge nexus. And here, not only will be testing your knowledge, but your typing speed as well. So it will consist of 10 questions, and we'll give 20 seconds to all the teams to respond in the chat box. You have to mention your team number like 1, 2, 3, 4, and whichever team will be responding the fastest will give that team the opportunity to answer. However, if the team cannot respond fast, then we have to go to the next team which has responded. So are we clear with the rules of this round, everyone?
Yes, ma'am.
Yeah. So further, there will be also 3 audience questions in between. And so the audience kindly participate. There will be prizes for you all. Okay. So Arshi, please, next slide. Okay, so this is a trial question. So kindly write in the chat box. I think if someone has already written, what is the capital of India? Team 4.
New Delhi, ma'am.
Yeah, okay, okay. So this is how it's going to work. So let's go to the next slide. So we'll be starting with the first question. Yeah. So which structure is the arrow pointing to? The inferior tarsus, orbital fat, tendon of inferior rectus muscle, and inferior orbital septum. So the first team to respond is team 3.
Team 1. Team 1 is the first to respond. They had written 3, 4, 2 afterwards. So it's team 1 right now.
Okay, okay. Fine. Team 1, please do respond.
Ma'am, A, inferior tarsus.
Okay.
Ma'am, team 1 has answered for the first question, ma'am. That this question, ma'am, XXX was not mentioned, ma'am. We only answered first one.
Just 1 second. Dr. Ashi, will you please see what
After the question was put up, it was team 1 who had written first. So the team 1 gets the chance first. Take success. A lot of you put it before the question was put up. All right.
Okay. So team 1, please do repeat your answer.
Ma'am, A, inferior tarsus.
Okay, so let's go to the answer. And you are absolutely correct. So team 1 gets the point for question number 1. So Arshi, please write XXX so that we can go to the next. Yeah, okay. So now let's go to the next question. So which one of the following is not seen more commonly in patients with keratoconus, Downs, atopic dermatitis, Ehlers-Danlos, and diabetes mellitus?
Team 3 gets to answer first.
So team 3, please do.
Atopic dermatitis, ma'am.
Okay, so let's go to the answer. So unfortunately, you are wrong. The answer is diabetes mellitus type 1. So next question. So now there's an audience question. So please, the teams, please don't respond here. So here's the audience question. For topical eye medication, the volume of one drop is approximately 10 microliter, 50, 100, and 150 microliter. So any audience? Audience, please do respond here. There are prizes for you guys too.
The audience needs to type in the chat.
So yeah, I think we have some answers here. And Mehek Gupta has responded. Yeah, absolutely correct. So it's B, 50 microliter. So Dr. Ashi, I think Mehek Gupta gets the prize for this round.
Yes, absolutely.
Yeah, okay, okay. So congratulations, Dr. Mehek. So next question for the teams. Gonioscopy and iridoschisis is likely to reveal number A, narrow occludable angles, angle recession, angle neovascularization, and angle hyperpigmentation.
Team 2 gets to go first.
Okay, team 2.
D, angle hyperpigmentation.
Sorry?
D, angle hyperpigmentation.
Okay, so let's see the answer, whether you are right or wrong. Okay, so the answer was narrow occludable angles. Okay, so nobody gets the point for this quiz. So the next question. Yeah. Okay, just read it carefully. A middle-aged patient presents with bilateral granulomatous uveitis with multiple serous retinal detachments. There is no prior ocular history and no history of trauma. Fluorescent angiography is most likely to show a single smokestack of fluorescent leakage into the subretinal fluid, multiple pinpoint areas of fluorescent leakage into the subretinal space, well-defined lacy hyperfluorescence with lead leakage, and diffuse retinal venous staining and leakage.
Team 4 gets to answer first.
Ma'am, it's B, multiple pinpoint areas of fluorescein leakage into the subretinal space. Okay, let's go to the answer. Yeah, absolutely correct. So team 4 gets the point for this round. Yeah. So next question, the clinical distinction between a cavernous sinus syndrome and an orbital apex syndrome is best made by the dysfunction of which cranial nerve? Cranial nerve 2, 3, 5 or 6?
Team 2 gets to go first.
Okay.
Ma'am, option A, cranial nerve 2.
Okay. So let's see the answer for this quiz. And yeah, you are absolutely correct. So team, this was team 2, right?
Yes, ma'am. Yes, ma'am.
Yes, team 2.
Yeah, team 2 gets the point for quiz number 5. So I think we are going to have an audience question now. Yeah. So audience, please get ready. The visual field defect most characteristic of optic neuritis is altitudinal, central, centrocecal or arcuate. This is for the audience. Yeah. See Mehak Gupta has again answered A. Okay. So let's see the answer. So answer is B. And I think Dr. Rohit Gupta is the first person to answer.
Dr. Rohit wrote it the moment you put the answer on, so we'll give it to him though.
Yeah, okay, okay. Anyways, yeah. So congratulations, Dr. Rohit. You get the prize for this round. Yeah. So next question for the participants. Quiz number 6. Yeah. All of the following are features of mucormycosis except internal ophthalmoplegia, ipsilateral cranial nerve 7 palsy, diplopia, and involvement of the first branch of trigeminal nerve. So I think team
2 gets
yeah.
to answer first.
Yeah, team 2.
Ma'am, option A, internal ophthalmoplegia.
Okay, so let's see the answer. So the answer is B. So nobody gets the point for this round. Next question, please. Yeah. Which of the following is true for the given pathology? Most common vascular tumor of the orbit. Oral propranolol is preferred for larger lesions, usually arises at puberty, and pulsed dye laser therapy is efficacious for superficial lesions.
Team 4. So 4, I'm
to.
going to give it to you right now, but next time, the moment I type XXX, don't write the number right then. Write it after the question is displayed. If you guys do that the next time, none of you will get to answer the next question. All right? So team 4 goes.
Team 4.
C, ma'am.
Okay. So the answer is absolutely correct. It's C. So team 4 gets the answer, gets the point for question number 7. Yeah. Okay. So just look at this picture and which gene is primarily associated with the disease, which has been depicted here. RPA65, RS1, ABCA4 or CFH gene. I think
4
yeah. Team 4 again.
C, ma'am.
Ma'am, it's C, ABCA4. Okay. So no, this is retinocheisin and you can see the characteristic cartwheel appearance here. And this is an RS1 gene, which is
Right,
associated. Yeah. Okay. So nobody gets the point for this round. Yeah. So next question, please.
Just a second. I just wrote XXX. Already 2 teams have written 2 and 3. Is the question out yet?
Yeah.
Wait. Okay. I'm going to write XX again. Please write your team numbers the moment the question comes in.
Yeah. Just please wait for the question to be displayed because you are losing on marks only if you don't see the question and reply, right? Yeah.
Okay.
Yeah. Okay. The inferior oblique muscle is weakened most by which procedure? Disinsertion, recession, myotomy, or anteriorization?
Team 2, please.
Ma'am, option C, myotomy.
Okay. And the answer is anteriorization. So nobody gets the point for this round as well. Okay. So the last question before we go to the audience question. So this is the last question for the participants. What is the most likely diagnosis in the patient pictured here? Syphilis, herpetic disease, scleritis, or sarcoidosis? Team 4, I guess.
4 gets to answer. Hanji.
Yeah. Ma'am, D-sarcoidosis. Okay. Yes. The answer here is sarcoidosis. So team 4 gets the marks for question number 10. So the last audience question. So gear up audiences, you get a chance to win some prize here. Pseudotumor cerebri is most likely to cause a palsy by of which cranial nerve? 3, 4, 5 or 6. It's a very easy one. Yeah, and I can see Dr. Akshika has given the correct answer. Yeah, perfect. So Dr. Akshika Dhameja gets the prize for this round. Okay. So I think we are over with the quizzes. Dr. Ashi?
Yes, the quiz is over. So I think Dr. Neelam has the score for the quiz.
Yeah.
Team 1 made 1 point. Team 2 made 1 point. Dr. Neelam, can you confirm?
Yes, ma'am, yes.
That team 3 made 0 or 1? I think it's 0.
Team 3 also, ma'am, according to me, 1 point.
1 point, sorry. Team
And
3 also 1 point and team 4 made?
Team 4, 3
2
points, ma'am.
Okay.
Okay. So we come to the last round. Dr. Ashi, please do you
Absolutely.
Yeah. So round 4. So here you have to unscramble the words. So one pre-decided team member will play the round. There will be 6 jumble words which will be flashed on the screen, and you have only 1 minute to solve it. And one mark will be given for each correct answer which you give. Okay. So everyone is clear about the rules here? All the participants? Are we guys clear? Okay. So we'll have a trial round. So there are 6.
Apple, mango, pineapple, strawberries.
Sorry. Okay.
Please
There are
keep
6
yourself muted. Yes.
Yeah, there are 6 jumbled words here. You have to unscramble those. And anybody wants to volunteer here? This is a trial round. No marks will be given for this round.
We'll volunteer, ma'am.
Yeah, sure. Okay.
Ma'am, like 1 is apple, 2 is orange,
3 is banana.
3 is banana, 4 is mango, 5 is strawberry, and 6 is pineapple, ma'am.
Perfect. So now we'll be having more difficult words, and those will be based on ophthalmology. And most importantly, you will get 1 minute to solve it. Okay. Okay. So we'll come to the first team here, team 1.
Dr. Neelam, can you put the timer on?
Yeah.
The moment I'll start, please put the timer on for
1
1
minute, ma'am. Timer is not shared, ma'am.
The app has the timer. Dr.
I'll do it.
Ashmi, can you try? Because I'm sharing my screen, so it's going to be difficult for me.
Okay, ma'am. I got it.
Got it? Yeah. Okay.
All right,
Yes,
perfect.
ma'am.
Wait. You'll have to restart.
Ma'am.
Yeah, okay. I'll move ahead, okay?
Yeah.
All right.
So team 1, please be
team 1, please be ready.
Yeah. Team 1.
Okay, your time starts now.
Ma'am, first is gonioscopy, ma'am.
Can you just
Okay.
keep on telling us? Yeah.
And third is fluorescein.
Okay.
And
So
fourth is ranibizumab.
1 gonioscopy, 3 is fluorescent, 4 is ranibizumab.
Fifth is pseudophakia. Sixth is hyphema, ma'am.
Okay. And you are left with 2?
And second is keratoplasty.
Okay. So let's go to the answers and see how you have performed. I think you have performed pretty well here.
Are they done answering all 6?
Yeah,
They still
they have
have
answered
9.
all 6. They have answered all 6. Okay. So first is gonioscopy, you are right. Second is keratoplasty, you are right. Third, fluorescent. Fourth, ranibizumab. Fifth, pseudophakia. And 6, hyphema. So they have answered all of them correctly. Well done, team 1.
Absolutely great. Could you reset the timer for the second team now? Team 2, ready?
Yes, ma'am.
Okay. Is the timer...
Yes,
Timer needs
is
to be
ready.
restarted. No, timer has to be stopped first. It's
Yeah.
at 20.
Yeah, it's at 20.
Perfect. All right. I'm going ahead.
Yeah. Team 2, please be ready. Vision virtuosos. These are your 6 jumbled words.
Ma'am, fourth one is hypopion.
Okay.
Third one is sixth one is syncytial scintillans.
Okay.
Fifth one is commotio retinae.
Okay. So you're done with 3 words. You are left with 3.
Vortex keratopathy. Third one is vortex keratopathy.
Okay. So 14 seconds left. Okay. And you are left with the
Time's up. Yes, time is up.
we'll just see how
So
you
they
have
have answered 4.
They have answered 5. They have answered number 1, brimonidine, which is right. They couldn't answer 2, number 2. Rest, vortex, keratopathy, hypopion, commercial retina, and syncytial sentinels. So they have answered 5 correctly. And well done, team 2. Arshi, I hope you are noting it down.
Yes, I am. We'll
Okay.
move on to team 3. Are you ready with the timer, Dr. Neelam? Yes, ma'am. All right, so I'm going to move. Start the timer, please. Yes, your time
Timolol.
starts
First one
now.
is timolol. Second, third one is aniridia. Fourth one is cornea. Second one.
Okay, first is timolol. Your third is aniridia. Fourth is cornea.
இது என்னமோ இது எவ்வளோ டைம் இருக்கு 21
You have 13 seconds left.
இது என்னது காரணி
Yes, time is up now.
Time is up.
Yes, they have answered 3, I guess.
Yeah, they have answered 3. So second was retinoscopy, and fifth was enophthalmus, and 6 was amblyopia. So they have answered 3 correctly out of 6 questions. Yeah. Okay. So let's go to the last round. Is the timer ready?
Yes, time is ready.
Okay. Team 4, be ready.
Yes, ma'am.
Yes, ma'am.
Your time starts now.
Pseudoexfoliation. Third one.
Ma'am, 3 pseudoexfoliation.
Okay.
Ma'am, 6 is
Iridodialysis, yes.
Ma'am, 6 is iridodialysis.
Okay.
Phacoemulsification.
Second is phacoemulsification.
Okay.
Ora serrata.
4 is ora serrata.
Okay. So you're left with 2.
Strabismus. Fifth is strabismus.
Fifth is strabismus.
Okay.
Time is up now.
Let's see how you have performed here. So the first you could not say it's Selznick spots. Second, phacoemulsification, pseudoexfoliation, ora serrata, strabismus, and iridodialysis. So you get 5 out of 6. Yeah.
Absolutely amazing performance by all 4 teams. I think we all have to agree that you guys did well in every round. What do you say, Dr. Mashmi, Dr. Neelam?
You guys
Yes,
were
ma'am.
right on time, and it was a beautiful illustration by all the teams.
Yes, everyone has put their efforts starting from the presentation to the reels, and they have participated well in the quiz round also and the jumble mumble round also. So every one of you have put good efforts, so keep it up.
And I hope you guys have learned also something today.
I
Because
think it's a wonderful opportunity that you guys had to interact with all the judges, and that you actually got to have a mock viva in a way. They were very supportive, and I think you all kept to time really well, and you had your mentors present, and great job on the unscramble. Actually, I was very surprised with how fast all of you were. Good team coordination. The quiz you guys could have done a little better, but better luck next time. That's absolutely always a way forward. You guys can keep learning. What do you say, moderators? We wrap up?
Yeah. Any comments from the teams?
Excuse me, ma'am. Our mentors have joined the webinar. Our HOD, Dr. Preeti Rawat, ma'am, and our consultant, Dr. Shweta Walia, ma'am, have joined. They're in the audience, ma'am.
Sure.
Can we have your mentors please switch their videos on and talk? Dr. Shweta, ma'am, it's nice to have you here, ma'am. Good afternoon.
Hi, Dr. Arshi. Good to see you. And the program was very good. And I had seen the entire discussion that was going on. And the questions Dr. Shushmita and Dr. Sunita Dubey and Dr. Satyan put up were very good. And even the case discussion were really, really very good. The seminars on angle recession, pseudoexfoliation, everything was wonderful. It was good learning for us also. Revise our concepts. Great going. YOSI, you rock.
Thank you so much, ma'am. I request all of you to put your cameras on again so we get a picture with the YO sign, the compulsory picture that we need, and thereafter we will give you all your certificates. All right, Dr. Mashmi?
Yes, perfect.
All right, perfect.
Will we-
Synergist, please put your video on this time. We didn't have you for the first picture. And all the audience, thank you so much for joining. So the audience awards have been won by Dr. Mehek and Dr. Rohit and Dr. Akshika, I think, right? So congratulations to you guys. We'll be dispatching it to you. We'll be in touch with you with your phone numbers. Can we have you guys on the screens too? Synergists, are you there? All right, you're there in another. All right, can we have the vice? Mr. Sai, can you help me take a picture, please?
I'll take it.
All right.
Just one. No, I don't think it's coming. Can anybody please volunteer?
I'll do it. Wait.
Yeah.
My Y has to wait. All right, got it.
Yeah.
Smile, guys. Okay, good job. I think Dr. Sai, Mr. Sai has also sent us pictures.
Yeah.
Okay, perfect.
So the results will be declared by, I think, in the evening, right?
Yes, we'll get all the Excel sheets from the judges and we'll compile the marks from how you performed in the quiz and in the unscramble round. You'll get exactly the number of points according to the mark questions or the answers that you've given, all right? The number of questions you've got correct. So I'll just share my screen again for the certificate distribution and then we can wrap up. So, Dr. Rishabh Khare, Dr. Srishti Upadhyay, Dr. Arpita Shringi, a big round of applause to the first team. The second team, Dr. Aishwarya K, Dr. Meghna, Dr. Sabrinath Arunagiri. The third team again from Arvind Eye Institute, Dr. Varsha Chauhan, Dr. Mehek Agarwal, and Dr. Sharan. And then we have the last team, Dr. Shobna, Dr. Neha, and Dr. Vanita. I hope you all got to see your certificates. We will be sending you these certificates as well.
Thank you, ma'am. Thank you.
Thank you so much. I'll be putting up your certificates on the WhatsApp group that you're part of, and we will post the results on all the forums. Do join us for the next round next Sunday. It'll be wonderful to see you all part of the audience. And I think that's it. Bye, guys.
Bye, guys. Thank you so much for such a wonderful evening.
Bye, everyone.
Thank you, ma'am.
Bye.
Thank you.
Good afternoon.